Thank you, and good morning again to everybody. I have the pleasure of presenting the quality of care results. And quality of care at the time of birth, that's the title of my session. And I'm going to present the findings from selected countries, so it's multi-country findings. And I must say it's really good for us to remember again, as Jeff has said, that whatever happens to the mother during labor and delivery really impacts on the baby. So I would like to make the clarification that most of the findings that I'm going to really present are focusing more on specific newborn health issues. But that doesn't mean that we're forgetting about the mother, but specifically focusing on the newborn. First of all, I'd like to acknowledge the country ministries of health where these studies were conducted and the staff at the study health facilities in Ethiopia, Madagascar, Rwanda, United Republic of Tanzania, so that includes mainland Tanzania and Zanzibar, Kenya, Mozambique, and Malawi. And also thanks to the data collection teams in each country and the MCHIP Quality of Care Research Team and the Malawi HBB research teams, and all those names listed there. And MCHIP Japago headquarters and the in-country staff, and research firms which were used in Kenya and Madagascar. My presentation outline, I'm going to give a summary of the quality of care study sample, then some inventory findings in terms of newborn care equipment and supplies in those facilities, the findings on the immediate newborn care and the practice, and then focusing a little bit more on newborn resuscitation findings, and then really pulling out Malawi as an example for helping babies breathe, newborn resuscitation, where a performance evaluation happened, and making some conclusion, which will be very general to the studies done, and also some related recommendations. If we look at the study sample, and you can see all the countries listed there, we decided to separate Tanzania and Zanzibar just so that we can see what the differences are within those two, even though they're within one United Republic. So we surveyed 643 facilities in 6 countries and observed approximately 5,600 deliveries and antenatal care consultations, and interviewed about 1,000 health workers. And the countries that are represented there, Kenya, Ethiopia, then Tanzania with Zanzibar, Rwanda, Madagascar, Mozambique. And we looked at the different facilities, and the total was 643, and you can see some countries had a lot of facilities where observations and interviews were made. In Kenya, having quite a high number, and then some had a very few, like 19 in Ethiopia and so forth. And we looked at, the study was done in hospital setting and then also at health centers and dispensaries, depending on the country. And observations of care were made in terms of deliveries and looking at newborn and postpartum care, intrapartum complications, and for the newborn, really looking at what happens during newborn resuscitation, and also focusing on the antenatal care consultations. And several health workers were also interviewed, as you can see there. Apologies, our slides are rather colorful and busy, but looking at the immediate newborn care as observed, for those countries there which are color-coded, Kenya, Ethiopia, Tanzania, and Zanzibar separated out, Rwanda, Madagascar, and Mozambique, you can see we looked at immediate drying of the baby with a towel, and that was done pretty well. Just looking at all of them together was about 81%, so people are doing that, but you can see some of the countries like Zanzibar, the places like Zanzibar, where it was actually quite low with a green bar. And then looking at whether the providers did discard the wet towel and then really cover the baby with a dry towel to ensure that the baby is warm. That was done not as well as the initial one, and that was like 63%. And then looking at cutting the cord and with a clean blade, and I think that is done pretty well because this is a message I think we've given for a long time. And then really looking at assisting the mother to initiate breastfeeding. And unfortunately, this really is really down considering how long we've tried to promote breastfeeding within all the settings that we work. And you can see the variation with some countries, actually the highest reaching about 80%, just a bit over, and the lowest really right down to about 20%. So I think there's really a lot more work that we need to do based on these studies. And then looking at placing the baby skin to skin. And I think we heard earlier really the importance of doing this given that preterm complications are causing a lot of newborn deaths. So that was 43. We still haven't reached where we should be. And then tying and clamping the cord. And I think this is something that has also really been emphasized, and that was done a little bit better. Then we looked at the inventory of supplies for immediate newborn care and looking at disposable cord ties or clamps, and that again was mean about 69% with, of course, the country variations. Towel or blanket to wrap the baby, and that we found many times that in the settings there's something to wipe the baby, but there's never something to really wrap the baby that's provided, and sometimes we're scrambling to really get that baby warm. Then using sterile scissors or blade to cut the cord, and that's also high, consistent with the previous slide. And then the mean score in terms of all the essential supplies ranged between 48 to 81%, depending on the country and depending on the facility, realizing some of the peripheral facilities might not be as well equipped as the central level facilities, so a mean of 65. When we looked at the inventory of supplies for management of newborn complications, and especially looking at babies who may be asphyxiated, were there facilities for resuscitation, babies who would be having newborn infection, were the antibiotics there, and were babies who are low birth weight able to have access to heat source or be kept warm. And again, looking at the mean findings for all those countries, for bag and mask, infant size was about almost 80%, with suction valve being a bit lower. And I think more needs to be done also there, so that considering that most babies, once the airway is cleared, then they will be able to breathe without additional assistance. And then suction apparatus using a catheter or a suction valve, as I said before, then that was, suction catheters were used more, and you can see that's a higher percentage, 77%. And then resuscitation table for the newborn, this was in some facilities up to almost 70%. And then having available antibiotics, gentamicin, ampicillin, and you can see the variation there. Ampicillin, gentamicin, surprisingly, is a little bit higher than the ampicillin, when most times it's the other way around, but within these studies, that's what was found. And then really having either functioning incubator for the babies who may need incubator care and are not stable enough for kangaroo mother care, or other heat source. This was like half the facilities. But you can see the range depending on high and low. Some had quite a good proportion, while others were on the lower end. And then we looked at the mean, and it was about 6% for all those supplies for such complications. When we looked at health worker knowledge of immediate newborn care and management of these complications, we looked at first at the equipment in general, and that was 38%, which we expect that to be higher. And then for immediate newborn care knowledge, again, was about 54%, and I think with the work we're doing in many of our programs and with the countries, we expect that really to be much improved. But sometimes knowledge doesn't always translate into action. And then signs Signs of sepsis in the newborn, that again, the knowledge was up to 61%. And then care of low birth weight baby, that's on the lower side, 43%, less than half. And then newborn resuscitation, which you can see two figures there. And it ranged from 28% and to 53%. So I think all these slides are showing us that we really still have work to do, even on the knowledge end. We tried to look at essential newborn care cascade, and we were looking to see, does having a policy or service delivery guidelines really make a difference? And you can see with that cascade, starting from the left side of the slide with policy, where countries had both policy related to newborn care, essential newborn care, and even had service delivery guidelines. All those countries really had that, and you can see the 100%. But when it comes to actually practice, you can see the slide moving downwards, and there's less proportion for skilled birth attendants. And then supervision, we looked at supervision if people were supervised for this kind of care within 3 months and also within 6 months. And then looking at the mean score for essential supplies, again, that was about 65%. And then the score for immediate care knowledge, again, that's coming down to a lower, and then 23% for the last item there. So it again highlights what we still need to do in the different countries. We also looked at some of the non-beneficial practices that are happening and non-indicated, and this was just out of interest and also to see what things are there that we really need to discourage. And we found that a small proportion of people are still slapping the newborn. Others are holding the newborn upside down. And we found in one country that there's a practice of milking the newborn's chest. So that could be a cultural practice, but it was less than 1%, so it may not be really significant. And then routine aspiration of the newborn's mouth, at least that is going down, because we know the recommendation now that aspiration is not really routinely indicated. And then we did look at some simulations of newborn resuscitation where we couldn't do direct observation of an actual resuscitation happening. We looked at simulation of resuscitation, and looking at the different steps from drying and positioning up to adjustments. So with drying and positioning, really that was like at half of all those, 53%. And suction of the mouth and nose with a bulb or with a catheter, that was at 84%. And remembering that people had a habit of already suctioning even when not indicated, you can see that that's a practice that's kind of been ingrained. So with newborn resuscitation indicated, and that is happening, and it's quite a high proportion. Then ventilation, that was on the lower end in terms of simulation, where we were expecting people to place the mask correctly and, form a seal, and then be able to help the baby to breathe, and really correct positioning and, just handling the bag and mask, and also be able to ventilate the baby at 40 breaths per minute, so that at normal rate, and that was really low, so we have a lot of work to do on that. And then adjustment was actually seen at 74%, so repositioning, head, neck, and so forth. But it may not, given that ventilation had a low proportion, it may be that those adjustments were made, but then the actual ventilation was not adequate. And then we did some observations on also management of newborn asphyxia for 230 cases of resuscitation observed. Unfortunately, this slide is incomplete as the analysis of all the data is still going on, but we did look at the steps performed correctly: drying and positioning, suction, ventilation, and adjustment, as highlighted in the slide before. And in terms of the outcome of the newborn, so in those observations, out of 230 babies, 208, the outcome, they were alive after the intervention, and 22 unfortunately died. I'm going to highlight Malawi as a specific country example where helping babies breathe performance evaluation has been done in 2012. Currently, we have all the data and results, but they're still being analyzed, so I'll just give a snapshot of what we found so far. And this evaluation was conducted by MCHIP and in collaboration with the Malawi Ministry of Health and other key actors. And the findings are available from the first phase of data collection for the newborn resuscitation HBB approach. 81 facilities were sampled in Malawi, and an inventory again was done of the essential newborn care, including HBB supplies and equipments. And an assessment was also made of the health worker skills and simulation as described before, bag and mask ventilation, and then really observing immediate essential newborn care and also how were these babies managed. And just looking at an inventory of the equipment for newborn care, 81 facilities, as I said, we went into those facilities and we looked at the bag and mask availability, tube and mask in some facilities, whether there was an incubator for those who needed incubator care, another source of heat for premature babies. And we can see that other sources of heat kind of was lacking in quite a number of facilities, and the information was also not available. So the greater emphasis needed really on a source of heat, especially for premature low birth weight babies. We also looked to see if there was a newborn weighing scale so that we know that our baby's not thriving because they're really in the danger point as far as their weight is concerned. And we looked at the suction bulb for mucus extraction and then the other suction apparatus, whether with catheter, recognizing that not everybody has actually implemented helping babies breathe where there is a suction bulb that's really easy to use. And then also looking to see if there was a resuscitation table for newborns. And in many of the services that we support at country level, you may find that the labor ward doesn't really have space. So it's really important, should a baby be asphyxiated, then there is a space to actually help that baby breathe. And then looked at the other immediate newborn care equipments like disposable cord ties and a blanket or a wrap to keep the baby warm. And you can see all those percentages there. There are a lot of figures there, but I think when you do get the presentations later, you'll be able to look at them more closely. And then we looked at simulation in terms of the key steps in Malawi, again, assessment of the worker skills, bag and mask ventilation, and looking at 10 key steps. If you look at the bottom of the slide, you can see that the mean number of steps done correctly was 6.1, so about 6 out of 10. And there are areas of focus that need more concentration. So really, we looked at the first two, which are checking equipment and selecting the correct mask, and then applying the mask to make a firm seal, and then improving ventilation. So you can see the scores there for those facilities that were studied. And then also observing immediate newborn care, similar to the initial slides I showed. Those were the findings. And then we looked at the preliminary findings in terms of management to see really, to do a flow chart of what happened to the babies that were seen. So of 231 not breathing at birth, we had, looking on the left side, 164 received stimulation and 89 ended up breathing, but 75 were not breathing. And for those who are not breathing, then 68 were assisted to breathe with bag and mask, and 62 started breathing, but 6 were unsuccessful. Where we've written unsuccessful, we still need to analyze the data to know what was really the final outcome of that baby. And for those who were not breathing even after stimulation and then had bag and mask, 4 were breathing and 1 was, the bag and mask ventilation was unsuccessful, and 2 had no data. But for the others, the 13, there was missing data, and 54 received no stimulation, but 47 were breathing and some were successful. There's also some missing data. So what conclusions can we make really from this, just those studies, but recognizing there are other factors that come into place that haven't been highlighted here? I think there's a big assumption that skilled birth attendance equals quality of newborn care, and this is really not exactly true. And there's still much to be done to improve the quality of newborn care for babies delivered at health facilities. And a sizable proportion of health facilities, including in the study, have newborn resuscitation equipment, but the provider skills need further strengthening. So from this, we have some general recommendations, but which will be really made more specific based on country level at a later date as we continue to work with the countries. Although countries are committed to make the quality of care improvements, additional efforts are needed to strengthen health provider skills, competence and practice, and this could be done through ongoing mentorship and in-service training, and also really pre-service training so that students come out knowing this but continuing to practice. We need also to avail the necessary life-saving commodities, and I think we heard that in an earlier session during this conference, including looking really at supply and logistics management so that the supplies do get to where they're needed and don't just stay at central level, but even to the last health center where babies are born and are asphyxiated. Then having really appropriate policies and service delivery guidelines, but ensuring that these policies and guidelines translate into action. And then obviously strengthening supervision and monitoring. And with that, I'll say that we also need the resources to be able to do this. So really working in partnership with our ministries and so forth. Thank you.